Today we're going to discuss metabolic alkalosis and its compensations. So what is metabolic alkalosis? When there's an increase in serum bicarbonate, which is your HCO3 ion, this can happen due to the accumulation of alkali or the loss of acids. It is also associated with secondary increase in carbon dioxide arterial pressure, which is your PaCO2. So one has an impact on the other. So how does this happen in the body? The pH inside a cell is between 7.0 and 7.3, with 7 being neutral. Arterial blood pH is 7.35 to 7.45. So arterial blood gases are needed in order to diagnose acid-base disorders. If you have high serum bicarbonate, the cause could be metabolic alkalosis or respiratory acidosis. A blood pH as high as greater than 7.45 means low arterial blood hydrogen, which is your hydrogen ion. This is the definition of alkalemia. If you have a high serum bicarbonate, the alkalemia is due to respiratory alkalosis, whereas if the arterial pressure of the carbon dioxide is low, it would mean that alkalemia is caused by respiratory alkalosis. So where does the hydrogen ions and the bicarbonate ions get produced and regulated? Well, we're going to talk about the kidneys, we're going to talk about the glomeruli, we're going to talk about the proximal tubule, and we're going to talk about the loop of Henle a little bit. In this diagram, you're going to see how this relates to the information that I'm going to give you. The kidneys play a key role in regulating the acid-base balance. The glomeruli filters bicarbonate, and all of the bicarbonate filtered there is reabsorbed. So about 80% of the filtered bicarbonate is absorbed by the proximal tubule, okay? And you can see that on the diagram. They're showing you where, well, I thought they were. I guess they don't show you that one. What's going to happen is 80% is absorbed right there. 15% is absorbed by the thick ascending limb of the loop of Henle, okay? 5% is absorbed by the cortical collecting duct and the intermedullary collecting duct. So if you add that up, we have 80, 15, and 5. That's 100% of it. The cells regulate acid-base balance are intercalated cells. There are two subtypes. There are alpha intercalated cells and beta intercalated cells. The alpha cells secrete hydrogen ions, and the beta cells secrete your bicarbonate ions. The bicarbonate is secreted in exchange for chloride ions. The IMCD, which is your medullary collecting duct, your intermedullary collecting duct, does not contain any beta cells. In the alpha cells, the bicarbonate exits via the basolateral chloride bicarbonate exchanger. The beta cells producing the bicarbonate has it exiting into the tubular lumen over here using an apical chloride bicarbonate exchanger, and that's what you're going to see. And here's your bicarbonate, there's your chloride going in, your hydrogen's going this way, okay? So secretion of bicarbonate in the collecting ducts must have luminal chloride and is inhibited by the depletion of chloride. So chloride depletion increases the sodium delivery and reabsorption. This stimulates the secretion of potassium and hydrogen ions. Hypokalemia hinders bicarbonate excretion. This explains why it is necessary to correct hypokalemia in order to manage metabolic alkalosis. So let's talk about the case we're going to talk about today. We're going to talk about a patient that presents with acute kidney injury with severe metabolic alkalosis caused by habitual vomiting in an alcohol abuser with pyloric stenosis. We don't really get into the pyloric stenosis, but that is present in this particular patient. In 41 to 49% of alcohol abusers, they will present with acid-base disorders. Most involve metabolic acidosis due to alcohol ketoacidosis and lactic acidosis. The case we are discussing today is unique in the fact that we have a 47-year-old male alcohol abuser presenting with acute kidney injury and severe metabolic alkalosis and hypokalemia. So he's not following the 41 to 49%, he's in the other percentage. The 47-year-old male was transported to the emergency room complaining of weakness and a consciousness disorder impacting the last 3 days. A detailed history could not be obtained. Obviously, if he's unconscious, it's hard to obtain that. The only condition confirmed was the alcohol abuse. The quantity of alcohol was unclear at that time. The patient's height was 172 centimeters or 5'7", with a weight of 57 kilograms or 125.6 pounds. Reported blood pressure was 128/78 and a pulse rate of 82 beats per minute. Oxygen saturation was at 94% and 18 breaths per minute was the respiration rate. Laboratory data is in this chart. Okay, we have the full layout. Here's his pH. So the ones of note that I think you should see would be the pH of 7.689, the PaCO2 of 51.7, the bicarbonate was in here. The bicarbonate level was 61, and I know it was in there, I just can't find it at the moment, which would indicate severe metabolic alkalosis. Metabolic acidosis was also presented by a moderately high anion gap, and it may be on our next page of statistics that we see, with respiratory alkalosis. An abdominal computed tomography displayed a large volume of fluid collecting in the stomach, no atrophic kidney, and a collapsed inferior vena cava. So the diagnosis was consciousness disorder, volume depletion, and myopathy. These were accompanied by acute kidney injury, severe metabolic alkalosis, hypochloremia, and hypokalemia. Here's his chlorine level, his potassium level, his sodium level, excretion level of sodium, excretion level of potassium. So the patient was supplied with sodium, so initial treatment, let's talk about it. We're going to give him sodium chloride, potassium chloride via IV, fluid replacement, and he was showing gradual improvement. So the patient was supplied sodium chloride and potassium chloride via the central vein. Potassium chloride at 120 milliequivalents per day, and sodium chloride was at 350 milliequivalents per day, with a fluid replacement of 2,500 milliliters per day. All levels, including the excretion levels, were closely monitored. They wanted to keep track of how much he was excreting and what the levels of chlorine were in his urine or the levels of bicarbonate in his urine, just to see where he was at. After several days, the metabolic alkalosis normalized due to the chloride ion addition to his system. With the sodium chloride, potassium chloride, we're adding chloride ions in. The hypokalemia showed gradual improvement. The effects of normalization were that his consciousness disorder showed gradual improvement. That gave the opportunity to finish the medical history. They found out from the patient that they were consuming 3 liters of beer per day and habitually self-vomiting for the last 4 years due to postprandial nausea and abdominal distension. So they were eliminating all the chlorine and all of the stuff they needed out of their system when they were throwing up and vomiting. After day 8 of treatment in the hospital, the patient was able to consume food orally without complications. The patient was given the guidance that alcohol use was prohibited at this time. If the patient started using it again, and he would lead him back to the same pattern of habitual vomiting, and he would be in even worse constraints than what he is at this moment, because they were at least able to normalize most of his systems. So when they discharged the patient, it was finally on day 16. Serum chloride levels were at 106 milliequivalents per liter, and serum potassium levels were at 4.2 milliequivalents per liter. So the chart on this page right here shows the possible pathophysiology of this patient, showing the alcohol abuse, the intake disorder because they weren't eating the way they were supposed to. Obviously, gastric pyloric stenosis is going to come into play here. The loss of chloride is your hypochloremia. That comes from your habitual vomiting. Your hypokalemia, which leads to your metabolic alkalosis. That also leads to myopathy. Your volume depletion, your hyperenemia and hyperaldosteronism. Your acute kidney injury is going to help lead to your consciousness disorder, which so does your metabolic alkalosis. The high anion gap was the one thing that showed metabolic acidosis. So we have this, and this was a possible way that this person was presented using just the information that we gathered. So the patient had severe metabolic alkalosis with advanced renal failure. Advanced metabolic alkalosis presents an impaired ability to excrete bicarbonate in the urine, and the loss of acid or gaining of alkali should be seen. The acute kidney injury and the volume depletion led to decreases in the glomerular filtration ratio, which would lead to a reduced rate of bicarbonate excretion in the urine. In this case, severe alcohol abuse led to malnutrition, which would lead to a decreased intake of chloride and potassium. Self-vomiting impacted the chloride levels also, which further worsened the metabolic alkalosis. The patient also had a very low urine pH, so IV infusion of saline at 0.9% was utilized to increase the urine pH to a normal range between 7.5 to 8.5. So the conclusion is the patient came with severe volume depletion and pseudo-Bartter syndrome. This was due to the habitual vomiting. The habitual vomiting led to a loss of chloride, resulting in the patient presenting with severe metabolic alkalosis and acute kidney injury. That would be the synopsis of this particular patient.